Thank you. I'd like to thank Professor Hosni and the organizing committee for the opportunity to present and for inviting me to this excellent meeting. So I was asked to discuss what's new with the management of carotid artery disease. I think the first question is, are carotid interventions appropriate or beneficial in stroke prevention and death? Indeed for symptomatic disease, but questionable for asymptomatic disease. 29 years ago, the NASA trial came out, and it did show, in fact, that there was a significant decrease in stroke with carotid endarterectomy compared to medical therapy in symptomatic patients, and this risk reduction increased significantly with increasing degrees of stenosis. Interestingly, the risk was also accentuated if the patient had an ulcerated carotid plaque, which led to the notion that perhaps plaques did produce strokes not because of flow disturbances or hemodynamic alterations, but because of plaque disruption. And the overriding concept here is that for a given degree of stenosis, plaque structure can vary significantly, and that's why there is increased interest in detecting vulnerable plaques. In fact, this is confirmed histopathologically. If you look at symptomatic and asymptomatic carotid plaques removed at carotid endarterectomy, there are clear differences between both types of plaques, with a necrotic core being very close to the lumen, a thin fibrous cap, and a variable degree of calcification. If you look at carotid plaques by CT scans, this meta-analysis demonstrates that in fact symptomatic plaques tend to have more soft components, more degrees of ulceration, and have much more volume. In fact, about a year and a half ago, some work that I did with the group at Erasmus University in Holland, analyzing CT scans, does demonstrate that it is very possible to segment each axial cut and determine which area has calcification and which area has soft plaque or fibrous tissue based on the Hounsfield units. The preliminary findings were that juxtaluminal plaques do, in fact, the symptomatic plaques do have juxtaluminal low density regions with crater plaque burden, and this kind of information may help us in defining which plaques are asymptomatic and vulnerable. Now, carotid endarterectomy trials based on degree of stenosis have been performed for both symptomatic and asymptomatic plaques. The real issue is that for asymptomatic carotid disease, lipid-lowering, antihypertensive, antiplatelet drugs, and risk factor control and smoking, as well as now anticoagulation based on the COMPASS trial, were not tried in the past. And in fact, a meta-analysis does show that the risk of asymptomatic high-grade stenosis now approaches almost 1 to 2% per year with medical therapy. I'm going to talk very briefly on carotid artery stenting versus carotid endarterectomy. I think it's very clear from the European trials that, in fact, stenting is associated with a greater stroke risk compared to carotid endarterectomy. The CREST trial that was performed in the United States did not show a difference. Neither did the ACT1 trial for asymptomatic disease. And now there's the CREST-2 trial in the US and the ACS2 trial, which now involves a best medical therapy arm versus the best medical therapy with stenting versus carotid endarterectomy. And I think that either the CREST trial or the ACS2 trials will not show much of a difference between the three arms, because the risk of stroke from asymptomatic plaques is quite low with current best medical therapy. This review here shows a meta-analysis that was published just in September of 2019, and it basically shows that comparing carotid artery stenting with carotid endarterectomy, the 30-day stroke death rate is significantly higher for transfemoral carotid artery stenting versus carotid endarterectomy for both asymptomatic and symptomatic stenosis. The long-term risk of stroke was the same at 4% at 9 years. There is better outcomes to reduce stroke and death if carotid endarterectomy is performed in elderly patients over 70 years within 14 days of the event, and if those patients do not require extensive stenting of the carotid artery. Of note that the white matter lesions were more common with carotid artery stenting on MRI versus carotid endarterectomy. The European guidelines do tell us a little bit about the subgroup of asymptomatic patients at a high risk of stroke on best medical therapy alone. And these include silent infarction on CTA or MRI, TCD evidence, transcranial Doppler evidence of emboli, duplex ultrasound progression more than 20% over 6 months, a large plaque burden, and a large juxtaluminal black area on computerized plaque analysis, as I mentioned previously, plaque echolucency on ultrasound, and impaired cerebrovascular reserve. This is all provided that the perioperative stroke and death rate is less than 3%. A newcomer for the management of carotid artery disease is the transcarotid artery revascularization, or TCAR, which includes flow reversal and filtering of the debris, and then restoring the flow back into the femoral vein. The initial trial, the Roadster trial, was performed in very high-risk patients, as you can see here, with anatomic and physiologic high-risk criteria. It must be noted that 75% of these patients were asymptomatic. But the results were very promising, showing that the Roadster trial had a lower stroke risk compared to other trials comparing transfemoral carotid artery stenting with carotid endarterectomy. Just recently, there have been 2 studies using the VQI registry in the US, comparing transcarotid artery revascularization versus transfemoral. And basically, TCAR does have a lower stroke risk compared to transfemoral carotid artery stenting, and equivalent stroke risk compared to carotid endarterectomy. So in conclusions, we await the results of the CREST-2 and ACS2 trials for asymptomatic disease. These trials, I suspect, will not show a significant difference. I think that further trials are needed to assess plaque structural imaging for the detection of those asymptomatic vulnerable plaques, particularly that 90% of asymptomatic patients will remain asymptomatic without any stroke. It is obvious from meta-analyses and systematic reviews that CEA, carotid endarterectomy, is safer than transfemoral carotid artery stenting, and that transcarotid artery revascularization is gaining traction as an alternative to both these interventions. Thank you very much.